Hi, everybody. It is so exciting and such a privilege to come together today with all of you for our second annual Bridging the Divide Symposium. So thank you all for being here, and most important, for the work you do all the time to improve care and advance equity for people with cancer and mental illness. So basically, the point is, we started this in an office as an idea, and right now we have more than 50 organizations represented: hospitals, universities, community mental health agencies, from as far as Dublin to Seattle to many places in Boston. So I wanted to just thank you all for being here and hope that it's helpful to know, because it was helpful for me last year and for other people to know that there's this community of diverse people that really care about this and are committed, whether as a clinician or as a patient or family member or advocate or politician, that you care about this and you're here because you care, and that together we're going to change the dialogue and hopefully close the cancer mortality gap for people with serious mental illness. So I'm going to turn it over to Dave Ryan, who is the clinical director of the Cancer Center and a GI oncologist and a really wonderful advocate for the seriously mentally ill.
So thank you, everybody, for coming. And I want to thank Kelly for being the driving force for tackling this really important issue, which is the intersection of cancer and the severely mentally ill. You know, a lot of us come to this with a passion, and I think when I look across the Cancer Center, we have this incredible ecosystem in Boston within the healthcare system. There's two ingredients that are necessary for change and for improving and innovating, and those are love and discipline. And I think one of the great aspects about you and this group is this love and passion for the severely mentally ill and mental illness in general. And I think it probably comes from a personal spot for many of you. It sure does for me. I can tell you that almost every family, I think, experiences it. And in my particular family, I watched my mom care for her sister with severe mental illness. And it was really just about love and her passion for being an advocate for her sister as she navigated life. And watching that as a nephew and as a child made an incredible impact on me. But I'm going to tell you a story about discipline that I'm going to challenge this group, because when I look at cancer and bridging the divide with the severely mentally ill, what I see a lack of, I think, right now is discipline. But I think it's right there. I think the spark is there, and we're starting to do it, and we're starting to do it through projects that Kelly has initiated. So back when I was a young fellow, there was a thing called palliative care. And I didn't think I needed any help with palliative care when I was a young attending. I thought I was a pretty good doctor and I could take care of patients pretty darn good. And the palliative care community looked at me and my colleagues as somebody who, well, we needed help and all they want to do is give chemo. And I looked at the palliative care community as, geez, all they want to do is not give chemo. And there was this divide. And I'll never forget, we started a program. I was lumped together with Vicki Jackson. And then we had this young fellow, Jennifer Tummel, who came up and started to apply discipline. I loved oncology. I loved taking care of cancer patients. Vicki loved palliative care. She loved doing palliative care for cancer patients. But then we had the discipline of somebody who loved clinical trials and wanted to make a difference and wanted to innovate and do so in a disciplined fashion. And I'll never forget one of the first clinical trials. We enrolled one of my patients, and this was a clinical trial. Anybody who wanted to go on a phase 1 study, which is one of these first-in-human studies, was approached to enroll on a clinical trial. And the clinical trial was intensive palliative care while you were going through this phase 1 clinical trial, this novel drug. We'll call it azarubart. And if you refused to go on it, you didn't get the intensive palliative care, but you had to fill out a survey. And this person filled out a survey, this patient of mine. She refused to go on it. She was a real estate lawyer from the North End, became a lawyer as a second career, incredibly successful, really smart, great advocate for herself. And she wrote down the answer to why are you participating in this phase 1 trial. She had metastatic pancreatic cancer. Her median survival from the time of entering that study would be about 3 months for all people. And she said, because I want to be cured. She said, because I want to be cured. Well, we went back, the research team started laughing at me. I don't talk to my patients. Dave, what are you doing? This patient with pancreatic cancer spread all over the place, thinks they're going to be cured by this basically skyhook from half court phase 1 clinical trial. It taught me a lesson. It taught me a lesson that we needed to figure out how palliative care was going to interact with this particular patient, and it taught me the lesson of hope, that everybody has hope and everybody wants to hope. And I went back to her, and she said to me when I asked her, how come you put down, I want to be cured? That was the answer I got back. She said, Dave, I'm allowed to hope, aren't I? So I think when I come across folks who have severe mental illness and cancer, they're allowed to hope, and they're allowed to hope for something better than what they currently have. And you're going to hear some bad statistics today. But here's how it changed for palliative care, through disciplined clinical trials. Jennifer Temmel and her group applied disciplined clinical trials to the problem of palliative care and cancer, and it transformed over the last 10 years. It transformed the way we think about cancer care, it transformed the way we think about palliative care, and it transformed the lives of patients. What I want to challenge this group today, and what we started last year, is to transform the lives of people with severe mental illness who have cancer so that they can hope for something better than what currently exists today. And the way you're going to do that is with discipline, with clinical trials, with innovative studies that demonstrate what we're doing wrong, how do we do it better, and how do we innovate and develop new therapies for these patients with severe mental illness so that they can manage through their cancer journey. So with that challenge, I'm going to turn it over to the Commissioner of the Department of Mental Health here at Massachusetts, in the Commonwealth of Massachusetts, Joan Mikula. Thank you.
Good morning, everyone. Thank you so much for inviting me to participate in today's conference. I think the leadership of Dr. Ryan Kelly, what you're doing is quite remarkable, and today is such an opportunity for people to learn from each other. So I'm going to start out with some of those bad statistics. Individuals with serious mental illness die on average 25 years earlier than those in the general population, and they're dying from medical conditions, not from psychiatric conditions. 2/3 of them die from natural causes, relatively equally divided among cardiovascular, respiratory, and cancer causes. There is and this is a big one, there is a 30% higher case fatality rate from cancer in psychiatric patients, even though their incidence is no greater than in the general population. So we're obviously dealing with something here that goes beyond diagnosis and treatment, what enters into the fray. I'm not going to be able to stay for the whole day, but I'm going to stay for a little bit. But I'd like to just make a couple of comments. And some of them are related to some activities I've been involved in of late. And I want to share with you what I've heard from our Department of Mental Health clients and their families. In the governor's budget this year, this is not specific to cancer, but it's very specific to medical care. In the governor's budget for this year, and he's calling his budget the Year of Mental Health, he's proposed the highest increase ever in the Department of Mental Health's budget to create new ways for us to work with, service, and treat the 23,000 individuals who are adults who are clients of ours. And there are a lot of changes in what we're going to do. But the core change hinges on shifts in the healthcare delivery system and not staying where we are, which is at a theoretical interface between behavioral health and physical health, but in real time actually embracing and moving toward that kind of integration for the people that we serve. So let me tell you what I've heard from family members and from individuals, probably 400 or 500 of them over the course of the last 4 months. They've said, we don't really want this integration. We're not comfortable with our doctors having too keen an awareness of what's going on with us in terms of our mental illness. We feel judged, and we feel that our symptoms are not taken seriously. And I wonder how much of that plays into that 30% differential, or that some N of years out of that 25 years earlier. The cross-sectional and cross-transactional research that needs to occur is fundamental, but core and also fundamental, I think, has to do with our perceptions and our attitudes and our way of understanding individuals with a mental illness. They are like everybody else. We probably in this room, if 1 out of 4 adults in the United States have a mental illness, a certain number of people in this room, not insignificant, probably do. And so how do we really think about that somewhat differently? So I would urge you, as you look at opportunities for research and look at opportunities for engagement and look at opportunities for new ways of treatment, to really think about this facet of it as well. What we've incorporated, and there's what, Bob, where are you? Bob Rousseau? So what we've incorporated into our delivery model on the ground with clinical teams are what we call certified peer specialists. They're individuals who have lived experience, who are every much a key player in the clinical team as the mental health clinicians. It's a model that we could probably benefit from on the healthcare delivery side. And I know, Kelly, some of the work that you're doing has actually begun to move in that direction. So again, thank you for having me. I look forward to a robust conversation.
Thank you very much. Thank you, Commissioner Mikula. I'm so glad that you were able to join us and that the Department of Mental Health is so committed to equity and health and innovating around this. Is a really exciting year with a lot of innovation happening. It's a great time for the conference.